Good morning. Boker Tov. For those of you who weren't here yesterday, my name is Ron Litman. I helped Irene organize a little bit, but really very, very little. She did everything. And she asked me today to talk about the ISMP self-assessment tools for antithrombotics. So just to introduce myself again, I am a pediatric anesthesiologist from Philadelphia in the United States, and I am a medication safety specialist. I'm the medical director of ISMP, which stands for the Institute for Safe Medication Practices. We are the largest nonprofit in the world for medication safety. It was started by an amazing guy named Mike Cohen back about 30 years ago, and he is the heart and soul of ISMP. I'm a newcomer. I've been there for 4 or 5 years, and I'm still learning everything. And they were nice enough to send me to Israel to represent them, and I'm really happy to be here, so thank you. Irene asked me to talk about our self-assessment system, and specifically for antithrombotics, and she says to me, please convince everybody to use this. You have to really sell it. And my answer is, I'm just a messenger. The content will sell itself, and it's really very useful. And it's a way that ISMP has been helping hospitals assess their own practices to see whether or not they are up to date with the current standards. So, to begin. That's my email. If you have any questions. I think at the end of today, are we also doing questions at the end? I think I saw something, maybe. There's a panel at the end. So if you want to email me with your questions, you can either, I will answer them by email, or I can present them at the end of the day today. Or you can also use Twitter down there. I can do both. Okay, so we have a wonderful website with a lot of resources, so please, when you're done today, not during today, go to ismp.org. And there are many different kinds of tools and opportunities for education from our website. So this is the page on what we call the self-assessments. Self-assessments are tools that any institution, any person, it's all free, it's all available, can go onto our website and download. And it's I'll show you in a minute exactly. So today's lecture, I have 2 goals. The first is to just give you a superficial overview of the self-assessment program. And the second is to describe some initial results of the antithrombotic self-assessment for the direct-acting anticoagulants. So, in general, ISMP has 5 self-assessment programs, and they're supposed to help hospitals assess their processes for medication use, their safety risks. They want the hospitals to form teams of people who do this together, and they will sit around a table and discuss their practices in a very open way, and so that they can all discuss their strengths and weaknesses and see what parts of their own program need improvement. And that this way they can create a plan. And then finally, they can track their progress by going back to the self-assessment and seeing how they've done over time. So these are the 5 that ISMP has now. High alert medications, antithrombotics, which we're going to discuss today, community ambulatory pharmacy, oncology, and hospital medication systems. And you can go online to our website and see any of these. So the purposes of the antithrombotic self-assessment are, just in a very general sense, to heighten the awareness related to the safe use. So there are many things, if you go through there, that you will find that are new to you or that are surprising. And I've looked at it several times now, and there's so many items. I can't possibly describe them all here today, but I promise you, if you go through all the modules, you will be surprised at how much you will learn. And what they do is they give you opportunities for making small improvements and for reducing patient harm. And you create a baseline. You can see when you answer all the questions, you can see where you are and what you need to improve, and then you check over time. Okay, so this is what it looks like. And these are divided into 8 key elements. And I won't go, obviously it's too much to go into in a small talk like this today. I'm just here to introduce the topic, and all the subsequent speakers are going to give you much more information, much more granular detail. But we divide it into the patient, drug information, communication, drug storage, medication device acquisition, staff education, patient education, and then finally risk management. So initially, ISMP came out with their first self-assessment in 2005, but that was focused really on warfarin, low molecular weight heparin, and unfractionated heparin. But in 2017, with all the new anticoagulants coming out that were oral, we did a revision, and the revision process was long. I didn't want to get into it too much because of time here, but those are mainly focused on these 4 drugs, which I probably can't pronounce if I tried, and as you could see. But what happened is it also includes some statements regarding some of the thrombolytic agents like alteplase, but it's so many questions. There are 125 statements altogether. Here's what it actually looks like. So when you go on to the self-assessment, you could see that there are many different questions, and they're divided into these core characteristics. And this is just a small example. It would take too much time and detail to show you. But if you could see here the columns A, B, and C, A has been no activity to implement this item, B, partially, and C, fully implemented. And I'm not obviously going to read off all of them, but you can see some examples here of what it's like to take these things and to see what it's like in your own institution. So for example, just number 3, a serum creatinine is ordered when initiating therapy with a DOAC. So these are the kinds of things that you want to, they're mainly just very large checklists that you go through with your team. And so what I'd like to do today is give you some of the 2017, you have to remember, once ISMP puts this out, it takes time for all the institutions around literally the world who want to use this to take it, to sit down with their teams, and then report back to ISMP. And you don't have to report back. You can if you want, but it's a really nice way that you can compare your results with other institutions to see how you're doing. And ISMP then has the opportunity to report it to the public. So for 2017, it's only a couple years ago, and we don't have full results yet, but here are some of the initial results. So what's some of the safety concerns with the DOACs? I want to make sure that we get this all on the mic here. So one of the things that they found is that there's really variable doses and frequencies based on the indication. Across the board, if you pick a specific indication, there are many different ways that people will prescribe. And so that can be good in one way, that people are thinking about individual therapy, but on the other hand, it speaks against standardization and consistent practice. Duplicate therapy was one of the most common problems that we saw with the DOACs, in that patients were getting lots of duplications between inpatient and ambulatory use, and not only that, but as Elliot talked about before, polypharmacy. A lot of physicians don't realize what other physicians are prescribing, and it's very confusing for them. Monitoring was a problem because many places failed to monitor renal function over time. There's lack of a reversal agent for 3 of the 4 agents. And one of the problems we saw is this transition of care from the hospital to the home, and how you maintain a consistent monitoring and levels of the DOACs over time. So here's just some examples of some duplicate orders. You could see there was a DOAC with enoxaparin, a DOAC with warfarin. I'm not going to try to pronounce those, especially it would be hard enough in Hebrew, let alone English. Rivaroxaban. And then in one case, you could see that all 3 were ordered by different prescribers, but then given by the same pharmacy, which is crazy, of course. Another consistent finding was that the doses were not adjusted based on renal function. And this is just another example here. One patient had an an elevated serum creatinine of 14.5, which is very, very high. And they did not alter the dose. So here are just some more examples that we found from some of the results. The rivaroxaban starter pack was ordered at discharge, but in fact, the patient was taking it for atrial fibrillation, which is another dose altogether. So you have to just really be careful on discharge what the indication is for the anticoagulant and to make sure that you're in the right dosing range. Another example is the patient was giving 2 prescriptions. Why they were giving 2 prescriptions, who knows? You know, maybe at least in my hospital system, most of the outpatient, once you're in the hospital, everything is done by electronic ordering, and the attending physician says to the resident, make sure when you discharge this patient that you give him a prescription for something, and you can only imagine that this resident may have told another resident, or maybe they both did at the same time, and it's hard to keep track. But this one patient took 2 different prescriptions of the same drug, but both different milligrams for 10 days. So these things happen. Yeah, that was her, let's see. Oh, and another one said hold anticoagulation, and it specifically mentioned 3 anticoagulants, but not the other one. So the patient got the other one. This is an interesting case where a patient was receiving enoxaparin and then was transitioned to a DOAC, but there was no, as we talked about this morning with the toxicologist, there was no information about any other drugs that could be CYP3A4 or glycoprotein inducers, and that patient was readmitted with a pulmonary embolus. So these are all things to think about when you send your patients home on DOACs. And these are the kinds of errors that we get reported to ISMP. Yesterday, I talked about one of the key ways that ISMP is able to report to the public about medication errors, and that's from self-reporting. And this self-assessment system is able to do the same thing for us as well. Here's a drug mix-up because of similar names. You can see that one, dabrafenib, was ordered instead of dabigatran. Same thing, it's very similar names. You have to be so careful. You know, the FDA is supposed to monitor the names of the drugs to make sure that there aren't 2 similarities to try and prevent mix-ups like this, but you know, they can't always do them all. So that's really the whole system. I don't think I have enough time to go into a lot of detail. I want the other speakers after me to do that more. But I'll just leave you with 3 key takeaways from the self-assessment system that we have. One of the things it does is it helps us understand the types of errors that have been reported. And the most common one so far with the DOACs is duplicate therapy. So the other key takeaway is to use the revised tool to help develop new strategies for reducing the risk. And then the last thing is that if you use the tool and you establish your own baseline, then it's really important to go back over time and see how you've improved, or maybe sometimes you've gotten worse, right? But the important thing that we'd like hospitals to do is to establish a team of people, the pharmacologists, the physicians, and nurses. You know, every hospital is going to be a little bit different as to what their team is, and go over the self-assessment and take the time to go over it carefully and really see how you're doing with your patients and how you adhere to all of these what are called best practices. So in summary, the self-assessment tool will give you really simple strategies that have been promoted by ISMP for over 20 years. And it gives you the opportunity to review them at a systemic level and to evaluate the way that you've either adhered to them or drifted away from them over time. And I'd be happy, I think probably have some time for questions. I don't know how we're doing on time, if anybody has. But like I say, this was really just an introduction to what ISMP can do for you. And I'll let some of the other speakers give you more specific detail about actual use of DOACs.